I would like to know the grade, lymphovascular emboli, perineural invasion, and if possible, depth of invasion also.
Okay. So, what was this?
This is the squamous cell carcinoma grade 2. Squamous cell carcinoma grade 2 with no evidence of lymphovascular emboli or perineural invasion.
It's a grade 2. Grade. So, it's a T2. T2. Grade 2 means you mean to say it's
grade 2 means it is intermediate.
Oh, grade 2 is okay. What is the T staging? Whether it's a T1, T2. Grade 2 is about the grade of the tumor.
Yes.
What did the biopsy tell you?
They didn't tell the depth of invasion.
Okay. So they didn't tell the depth of the invasion. Here we really don't know whether this disease is a T1 or a T2 disease. Okay. So is there any investigation to find out whether it's a T1 or T2?
One is clinical examination itself. If the injury is extensive to the shaft of the penis, we can grossly say that it is T2 or T3 disease, and we need to do MRI for the brain.
Okay. So this patient, how are you going to proceed?
The induration extends beyond 1 centimeter into the shaft of the penis, sir.
Okay.
So
it is going into the spongiosum or a cavernosum?
Into the cavernosum. That's a T3 disease, but it is just 1 centimeter into the shaft.
So if it is involving the glands, what do you call it as? T1, T2, T3? If it is involving the glands of the penis.
Yes, sir.
Okay. What do you call it as? T1 disease or T2 disease or T3 disease?
Based
you told me it's extending into the cavernosum. Okay, sir. Acceptably, it is a T3 disease. Probably we don't know. We haven't seen the patient. Okay. If it is involving the glands,
yes, sir.
Will you call it as a T1 disease?
Based on histology of this, whether perineural invasion or LVSA.
See, that is for LVSA, perineural invasion is between T1A and T1B. Okay. What you need to understand is glands is the extension of spongiosum.
Okay.
Okay. Yes. If glands is involved, it's a T2 disease. Okay. If it's confined to the subepithelial tissue, it's not going into the proper glands. It's a T1. Okay. Glands is involved. It's a T2 disease. Okay. There is no separate thing called as spongiosum and glands. Yes. Okay. So this becomes a T3 disease. And what about the node? Did you tell anything about the node?
No, sir. Clinically negative, sir.
Clinically negative. Do you want to do any investigation to find out the nodal status for this patient?
Yes, sir. I would like to do ultrasound of the bilateral inguinal region, and if any node is suspicious, I would like to do FNA.
Okay. So you are telling this is the T3 disease. Yes, sir. Don't you want to look at the pelvic nodes?
No, sir. Unless inguinal nodes are positive, it is unlikely to have a positive pelvic node of disease, sir.
So what you are telling is from the older version. Recently, what current teaching is, if it is a high risk disease with a node negative groin, still you do a cross sectional image. Okay, because this is a T3 disease. It comes under a high risk and no negative groin. Okay, can there be a pelvic metastasis without inguinal metastasis?
Very unlikely. It is usually penis goes in a systematic manner of superficial to deep in and into the pelvic nodes.
Still 1% of people can have a direct pelvic nodes. Okay. Yes. The classical teaching is first ichleon, second ichleon, all those things are there. Okay. But direct lymphatic communication between the penis and pelvic nodes are always there. Okay. Penetrance is there. But not common. Okay. Unless inguinal nodes are positive, it's not common. But here, this being a T2 disease or T3 disease, you still do a cross-sectional imaging. Okay. CT, MRI, whatever it is. Right? Whatever you want to do, you do it. But you need to have pelvic nodes also to be screened. Okay. Why we are so much bothered about the nodal status?
It is the most important prognostic indicator of disease. And also it changes the management, how to address.
Because if there is a node positive, you miss the disease. Okay. In those people, the 5-year survival is less than 10%. If there is a node positive disease, you have treated it appropriately, whatever the treatment is as per the current guidelines. The overall survival at 5 years is 80%. Okay. Same patient who has a node positive disease or micrometastasis in the node, you miss it, the survival falls by 70%. Okay. So that's a significant crux here. Okay. So this patient about the groin, sir, no negative groin, high risk. What do you want to do?
I would like to do
okay, ultrasound says there are few nodes. What are the ultrasound characteristics of that it could be a metastatic?
First is
what are the things you want to look at an ultrasound? What are you look for?
Hilar effacement is there or not, and the
what is hilar effacement? What do you mean by that?
The corticomedullary differences.
So whether the medulla will be hypoechoic or hyperechoic?
Medulla will be hyperechoic and the cortex will be hypoechoic. And the differentiation will be lost, and the size of the shape will be more rounded than reniform shape, and then reniform, and also increased vascularity and
increased vascularity, malignancy.
Yes, sir. Loss of the
brachydilem is the one-word answer I want from you. Okay.
Okay.
Hilum will be hyperechoic. It's a fat. Okay. When it becomes hypoechoic, suspect it to be a malignancy. You can have other additive points like capsule irregularity, whether disease has gone outside this hypoechoic thing has gone, continuity has gone outside the node, matted node, whatever it is. One word, what I need is a loss of fatty hilum. Okay, if it is there, it's probably malignancy. So this patient, will you go and do a FNAC of all those small nodes, or you want to do something else?
Recent guidelines told.
What you want to do? You are the treating physician. What do you want to do?
If anything is suspicious in ultrasound, I would like to do FNAC scan.
Okay.
If the nodes are normal, we can do surgical staging of that.
So anyhow, you want to do a surgical staging. What is the significance of doing an ultrasound and finding whether this could be a malignancy? Why do you want to do that?
Because if 2 or more nodes are positive or any external extension, we need to address the pelvic nodes also.
That your CT or your cross-sectional imaging would have given you.
Yes.
Why do you want to do a FNAC here? What additional information gives you?
Not very sure.
Ideally, this patient is a high risk. Okay.
If positive, then deep inguinal node.
See, you should have a clear plan. Okay. This is a clinically node negative. Okay. With a high risk features, primary. This needs a surgical staging. Minimum surgical staging is
superficially
DSLNB.
DSLNB or superficial.
Okay. If you have facilities for DSLNB, do a DSLNB. No negative groin with the high risk features should have a DSLNB done during the primary surgery. Okay. If you don't have facilities, you can look for a surgical staging. So how this DSLNB is done? What it is?
It is using a dual laser, radiocolloid and isosulfan blue or methylene blue. The technetium 99 is injected 4 hours before the surgery, and methylene blue is injected intradermally.
Methylene blue.
Isosulfan blue is injected during the procedure intradermally, and we are using the gamma probe, and by visual inspection we need to do the adherence.
And that should be sent for a frozen section.
It should be sent for frozen.
Okay. So you don't have the facilities for DSLNB. What do you want to do?
I would like to do superficial inguinal and bilateral superficial inguinal.
Bilateral. Why do you want to do bilateral?
Because penis is a central organ with risk of metastasis to both the groins.
Okay. So here you want to do standard or modified, open, endoscopy, what kind of technique you want to proceed?
I want to do preferably modified needle.
Okay. Open. How will you do?
By making a small incision and basically
Where do you put the incision?
2 centimeters below the inguinal crease, horizontal small incision, and we
Can you do with any other incisions?
Yes, sir.
What are those?
Can be lacius incision or oblique incision. Can also.
So tell us about clearly. See, if I ask you what are the surgical steps, tell me how you will do it.
Yes.
Okay, not a small incision, big incision, I don't need. I'll put an incision here, this area. That's how I proceed.
According to Dressler's zone, zone 1 and zone 4 will be addressed along with the zone.
What are zone 4 and zone?
1 and 4 medial zones, and there's around the subinguinal junction. So those area will be clear.
So as you told about zones, what are the zones of inguinal node? How many zones are there?
5 zones.
What are they?
Zone 1 is supromedial, and zone 2 is suprolateral, and zone 3 is infralateral, and zone 4 is inframedial, and zone 5 is around the subinguinal zone.
There is a central zone.
There's a central.
So you won't take the central zone.
Central zone on side.
You told me that you will address only 2 zones, right?
3 zones. 1 and 4 along with 5. Along with 5.
That's it. And you basically take the medial compartment and central compartment out. Okay. Don't give zone numbers.
Medial and central.
Okay. What I'll do is like the modified template, I'll take this area. Don't give a complex answers unless you are very sure about what you are speaking. Okay. So how many notes you want like to take out? How many more notes are there? The superficial group. So usually in each zone there are 5 lymph nodes. Okay, around 25 lymph nodes are there, and deep another 5 lymph nodes are there. Okay, so you do the superficial dissection on one side, and you will send it for frozen. Say only one node is positive in your frozen section. What will you do next?
You would like to do deep compartment also.
Okay, so deep compartment there are no nodes. Will you do pelvic node?
No, sir.
Okay. There are 2 nodes positive in the superficial compartment. What will you do?
Then also I would like to do deep compartment also.
Okay. Again, if deep compartment is negative,
I won't do pelvic.
If 3 nodes are positive,
in the superficial compartment, then also I won't do pelvic.
2 or 1
see, when you ask a discrete question, everything has a different answer. Okay.
More than 2 or 1 node with DME, we have to
So, nodes, 2 or more nodes in the superficial compartment. If superficial compartment is positive, you go further, one more compartment, deep compartment. Okay. If deep is positive, always you will pelvic node. Okay. Will you do a pelvic node on ipsilateral side or bilateral side?
Ipsilateral side.
There is controversy regarding that. Okay. You can tell. Routinely we follow ipsilateral. Okay. There are centers which follow bilateral template also. If deep compartment is positive, there is some 30% chance of cross spread to the other side.
Okay.
If imaging is not picking up any node on the other side, you can skip that side comfortably. Okay. It depends upon the center. Okay. MSKCC follows bilateral.
Okay.
So if 2 nodes, more than 2 nodes are positive, consider pelvic lymphadenectomy. Say that I do it. There's no harm in over treating. Okay. External extension is there. I will do pelvic. Okay. So you do superficial lymphadenectomy. There are no nodes positive. Will you still do the other side?
Yes, sir.
Other side complete or superficial?
Other side superficial.
Okay. Say one side 2 nodes are positive.
Yes, sir.
Other side you will do deep or not?
No, sir. I will do superficial and assess that side. If it is positive only, I will do deep, sir.
Okay. So will you do if nodes are positive, will you do standard template or modified template?
Nodes are positive, I will do standard templates.
Even though you have done a modified template initially, it's for surgical staging alone. It's not a curative procedure. If it is positive, you have to do a,
One positive.
if notes are positive, you do a standard template that includes the deep inguinal notes also. Okay. So what is Cabana something? What is a Cabana node?
Initially, it's a supromedial node which was initially as form of sentinel inflammation developed by Cabana.
So a very significant thing about this Cabanas is whatever sentinel we are doing now for the breast, head and neck, whatever it is, started in the beans. Okay. There it started. Now we have adapted the same technique to the other places also. Okay. So the sentinel node. Where exactly this Cabana is located? Not the person, but this node.
Node is in the supromedial portion of
Most commonly, this is located where the saphenous vein joins the femoral vein. Okay, that angle. Okay. That's the location where this Cabana's usual position. Okay. First sentinel node we call it as Cabana's, but usual position is just underneath the saphenous vein. Okay. So there's any other named nodes? What is this clocked node?
Clocked node.
Clocked node, medial most.
The pelvic node.
Lateral ligament.
Have you heard of this name clocked? Or what is it?
Lateral.
The femoral region, the medial to femoral vein.
So
just lateral
that is the highest level in your deep inguinal node. Okay. Just right underneath your inguinal ligament, medial to the back node ligament, you'll have this node. This is the clocked node. Okay. If clocked node is positive, invariably pelvic nodes are positive. Okay. And this clocked node needs to be taken out. Okay. And when you do this clocked node dissection, that's the most commonest area for a femoral hernia later on. That's where it communicates with the appendix. Okay. So this patient, you have done this one, superficial linguectomy. Notes are negative. How do you follow? Okay. Before we go into the follow, what are the complications you expect with this surgery?
Seroma, infections, hematoma formation, clamp necrosis, and immediately bleeding. Recurrence.
So whenever we tell about a complication, always tell the answer should be immediate and late. Okay. Subclass wise, immediate these two, delayed infection and clamp necrosis. Okay, later recurrence. So have you heard of the word femoral blowout?
Yes, sir.
What is it?
It is the invasion of femoral vessels by the node adjacent node, causing torrentous bleed.
So, do femoral blowout occur as a result of surgery?
Can occur.
Is it a complication of inguinal lymphadenectomy?
Yes, sir.
When do they occur?
When we do deep inguinal dissection and if we are not covering it with sartorius or any other clamps, it can happen. And when we leave
it's not vessel invasion alone. Okay. Say this patient has a deep node also. The femoral vein is involved, infiltrated by the tumor. What would you like to do? And there are no meds.
I would like to excise and repair the femoral vein. Along with
that, see, if surgical resection is possible, do it. Okay. And if you have known all these things prior to the surgery, that it is the N3 disease. We'll say N3 disease. How will you address it?
I would like to do neoadjuvant chemotherapy.
First neoadjuvant chemotherapy,
followed by reassessment and if
surgical
if
consultation.
it is
Okay. So this patient, if doesn't respond to your chemotherapy, this M3 disease,
yes, sir.
you're giving chemotherapy. What chemotherapy would you like to give?
The TAP, paclitaxel, ifosfamide, and cisplatin.
How will you give?
Paclitaxel 170